All right. Well, hello, everybody. Thank you all for tuning in this evening. It is wonderful to be here and take some time to discuss a very important topic during Oral Cancer Awareness Month. I am Franklin Van Valkenburg. I am the Associate Director for Constituent Engagement at the College of Science here at George Mason University. I just want to say thank you all for taking interest in this topic. And I would like to hand over here to Michelle Ryan and give her a moment to the Alumni chapter.
Good evening, good morning, good day to everyone. I'm Michelle Ryan, the chapter president for the College of Science Alumni Chapter. Welcome and thank you for joining us for our second edition of our webinar series showcasing the research and talents of not only our alumni, but also outside panelists. And with that, I will turn it over to Ida Kondori, who is a fellow board member for the College of Science Alumni Chapter.
Thanks, Michelle. Hi, everyone. My name is Ida Kondori, and I'm honored to serve now as the Vice President of the College of Science Alumni Chapter Board at George Mason. We have a great, fantastic, dedicated team that's working to strengthen the connection between alumni, students, faculty, and the broader community. And we're aiming to support the College of Science through mentorship, engagement, and outreach, while championing lifelong learning in the sciences. So I'm really excited to be part of events like this one that bring everyone together, healthcare professionals, researchers, and future leaders, since I know having these meaningful conversations really make a difference. And a big heartfelt thank you in advance to this team, Dr. Glass and Dr. Williams, for their presentations this evening.
And if I may, I'd like to take a moment for everyone to get to know the panelists in a little bit more detail before we begin the presentations. So I'd like to begin with Dr. Glass and allow her a couple moments to speak to her background experience and what she's bringing to the table this evening.
Well, thank you so much. I am so appreciative of being here and for the invitation. I'm excited to talk to you guys about oral cancer this evening. I am a board certified oral and maxillofacial pathologist. I am also an assistant professor at the VCU School of Dentistry.
Good evening. I'm Michelle Williams. I'm an associate professor in the Department of Global and Community Health at George Mason University. And my focus is on cancer prevention and control research, really focusing on cancer education and increasing engagement in preventive cancer screenings.
All right. And Ida, do you have anything else that you would like to speak to regarding your background experience before we begin?
Sure. Just, a little bit more about me. I'm a general dentist, and I'm also a professor at Northern Virginia Community College in the Health Sciences Department. I have a deep passion for improving patient care, not just chairside, but across the entire healthcare system. So thanks for having me.
Very good. Well, thank you. Now, without further ado, let's talk a little bit more about oral cancer. Dr. Glass, if I may, trouble you to bring up the presentation, and we'll go ahead and get started.
All right. Well, I hope you guys are ready to dive right in. So I'm really going to speak from the diagnostic standpoint. That's where my focus is as a pathologist. So really for this brief presentation, I want to talk about what that process looks like to make a diagnosis, really explore some oral systemic links because we know the mouth and the body are connected, and then also highlight some of the fantastic research that my students are doing here at the school. So to start off with, I feel like we should define a little bit more what oral cavity cancer is. When someone says oral cavity cancer, they most likely are referring specifically to squamous cell carcinoma that accounts for about 90% of the malignancies found in the oral cavity. But then our other 10% can include a variety of different malignancies. Those can be within the jawbone or soft tissue. They might arise from salivary glands, perhaps hematological malignancies, or even metastatic tumors from elsewhere in the body. So there are quite a few malignancies we can find in the oral cavity, and here are a few pictures for you of those. So here I have for you the most recent estimates from the American Cancer Society on the number of diagnoses expected in 2025 for both oral cavity and oral pharyngeal cancer. A lot of the statistics really lump these two malignancies together, although they're different in their etiologies, and we'll talk about that a little bit. But you can see here that the number is expected to be around 59,000 new cases. This is higher than numbers in the past. And we also have a graph here showing you the stage at which the cancer is, the stage of diagnosis of patients and really how far the cancer has spread at the time of diagnosis. We can see that the majority of these malignancies are diagnosed when they already demonstrate some regional spread, meaning they can find cancer within the lymph nodes of the neck. So ideally, we want to catch these as early as possible, more so in their localized stage. So here's just a list of some of the risk factors that are associated with oral cavity cancers. We really know tobacco and alcohol play a big role in both oral cavity malignancies as well as other malignancies across the body. You may be a little bit less familiar with areca nut and betel leaf. These are products used predominantly in Southeast Asia and other communities, which also carries a risk of increased oral cavity cancer. For cancers arising on the lips, we're concerned about UV radiation. Human papillomavirus is a risk factor for some of our HPV-driven tumors. This is specifically our oral pharyngeal cancer. And then, of course, some of our systemic conditions, whether those are hereditary cancer syndromes or immunosuppression, will put a patient at higher risk for the development of oral cancer. So sometimes the diagnostic process can be a little bit fuzzy, and so I just wanted to really elucidate that for you so you can see the process of how someone goes from detection all the way to treatment. And everything really starts with the critical step of a head and neck examination. This is predominantly performed by oral healthcare providers. We teach every dentist to perform this examination. And hopefully we'll get more medical providers on board with providing these screenings. These are typically done at routine appointments and is crucial in the first step of identifying any suspicious lesion. Now, if one is identified, typically the next step is a biopsy. This is where a surgical clinician, such as an oral and maxillofacial surgeon, will take a scalpel and remove a section of the tissue to send off for examination under the microscope. And that's really where I come in as a pathologist. So I will look at the tissue under the microscope and determine what the diagnosis is and have a conversation with the surgeon to relay that information. That surgeon will then have a conversation with the patient and typically refer them to a treatment center. The treatment center will have a multidisciplinary team. So it really is a group of people who come together to determine how they can help the patient navigate. And then ultimately, surveillance is required so that we can monitor patients and make sure they don't have a recurrence or a new primary. So that's really kind of the big overall view of how a patient is diagnosed and managed. And that takes me to one of our research projects done by one of our students. So she was really curious to see how many providers report performing extraoral and intraoral examinations on patients. And as you can expect, a lot of them are saying they are performing these exams. Now, if you look at the literature to see from the patient perspective, these are not the same numbers reflected by our patient population. So really the truth is probably somewhere in the middle. And I know you're going to hear a lot more about oral cavity examinations and oral cancer screenings later on this evening. So what exactly are our oral healthcare providers looking for? Well, really training our providers on what they're looking for is critical, and that's one of the things that I do as a teacher. And so these are a list of oral potentially malignant disorders, which is a really long term just to describe these conditions that are considered pre-malignant or have the potential to become malignant. So these are our red lesions that don't go away, our white lesions that don't go away. We are not sure what they are, and we need some more information, ideally a biopsy, in order to look at it under the microscope. These are also conditions that if a patient has them, they need to be surveilled over time to make sure that it doesn't end up developing a malignancy. And a lot of these have varying risks of transforming to a malignancy that we call their malignant transformation potential. So another student project where we took one of these oral potentially malignant disorders and looked to see at our patient population, specifically in our oral medicine clinic, to really see uh, what these patients really some key characteristics to see if they were the same as what we see in the literature. And this is one particular condition that I'm really focused on in my research, and that's proliferative verrucous leukoplakia. This is a very kind of high risk specialized form of leukoplakia. We typically see it more commonly in women, usually those that do not use tobacco products, and they have a very high risk of malignant transformation. So in our patient population, the majority of patients ended up developing a malignancy, often on the gingival tissue. So really identifying patients with these conditions early allow us to screen and be prepared for when they do end up developing a malignancy. So what are some signs and symptoms of oral cancer? The most common location is going to be the tongue and the floor of the mouth. So about 50% of our cancers are going to occur on the tongue, and most of the time they arise in one of those conditions I previously discussed. Things we're looking for and things we can teach our patients to look for when they're doing their own screenings are any masses or ulcerations that don't go away, surface changes where we have red and white discoloration or textures like granular or kind of warty looking changes, and certainly any areas of bone destruction and tooth mobility are really concerning signs. One of the problematic things about oral cancer is that typically they're not painful initially, so a person might delay making an appointment because there are not symptoms associated with it. And it's typically not until we see advanced cancers where we have pain and discomfort. So, another reason why patient education is so important. Here we have three examples for you. So here, some red and white discoloration. We have an exophytic mass on the lateral border of the tongue and a non-healing ulceration on the lateral border of the tongue. All three cases were squamous cell carcinoma when biopsied. So this is another student research project that I did with our students looking at specifically the locations of oral cavity cancers. We know what the most common locations are, but I specifically wanted to look at it from a dental perspective. So we get biopsies from all our oral healthcare providers, and it turns out that a lot of our oral healthcare providers are the ones diagnosing our gingival cancers. And these are really the ones that are typically a little bit harder to discern clinically. Maybe initially it's thought to be something reactive or inflammatory, but it's really our providers who are finding these malignancies. And so I like to highlight the need to check our other sites in addition to just the tongue and floor of the mouth. And here we have an example of a oral squamous cell carcinoma on the gingiva with an accompanying radiograph to show you the bone destruction associated with that lesion. So I also want to mention some signs and symptoms of oral pharyngeal cancer. A lot of us are detecting these malignancies as well. It's a lot harder to see the primary tumor, and that's because typically it's kind of embedded in the tonsils. Those have a lot of crypts. So we may have a small primary there or the base of the tongue. So a lot of times, the most common way these malignancies are detected is really through a enlarged lymph node on the neck. So in doing the extra oral portion of our head and neck exam, this is where we can detect signs of our oral pharyngeal cancers. Patients may have some symptoms associated with, such as a sore throat, pain, or difficulty swallowing that's persistent. This is what a squamous cell carcinoma looks like under the microscope. So we have our overlying surface epithelium here, but what we really see are these balls or islands of malignant epithelium. This is invading into the underlying connective tissue, replacing and destroying it, which is why a lot of times cancers will feel firm or indurated on palpation, and that's because of this invading tumor into our soft, squishy connective tissue. Another project that we're working on with our students, and this one's in progress as we speak, is really looking at incisional biopsy techniques with some of our surgical specialists. So in order to obtain a diagnosis, we need to perform a biopsy to get a tissue specimen, but where that biopsy is taken from, your site selection, is really critical in getting the most representative part to achieve a diagnosis. So we're really looking at this across the different specialties and seeing if there's any ways we can help bring some uniform teaching to that. Once a patient undergoes a biopsy and a diagnosis is made, this is where they're referred to a treatment center, and really our oncologist and our cancer treatment team talks in terms of our TNM staging. This really gives a lot of information in that it gives us the size of the tumor, whether or not there's lymph nodes involved, and whether or not it's spread to distant sites of the body. So this is the terminology that will be used to describe the extent of the tumor. And then from there, patients will undergo a variety of different therapies depending upon how extensive their cancer is, as well as what will respond the best to them. A lot of pathologists are really leaning into precision medicine to really see what can we do to help this specific patient with their specific tumor. And so here is the list of some of the different treatment methods we have. Really, most patients who have oral cavity cancer will undergo a resection. And so here I have an example of a resection specimen that we would see as a pathologist. And these are really extensive surgeries. They can be quite disfiguring, and they have a lot of challenges that patients will have to navigate afterwards, which is why, again, it's so critical that we catch these when they're at a smaller stage so we can avoid these really extensive surgeries. Patients may also need to undergo radiation and chemotherapy. There's some new medications out there, targeted therapy and immunotherapy patients may undergo, and then certainly pain control as well. The 5-year survival rate, kind of pooled for all oral cavity malignancies, is around 69%. And as I alluded to, there's lots of effects that patients experience when they're undergoing cancer therapy. Here are a few examples of people who've been really brave to talk about their experiences and help other patients navigate. So here we have an example where Liz had a portion of her skin removed from her arm to reconstruct her tongue after a partial glossectomy. Rick had his mandible removed and he elected not to reconstruct it, so you can see some of the disfigurement caused by that surgery. And then finally, Eva had a cancer of her tongue as well, but required a neck dissection. And during the neck dissection, they actually had to take the sternocleidomastoid muscle because of the extent of the cancer spread. So she had to undergo physical therapy just to learn how to lift up her head again. So patients really have a care team from all perspectives in order to help them with their therapy. So what we can really do to help bring education to our patients, to our communities, is to really emphasize some of the things that will provide us some protection. That's habit cessation for some of our risk factors that are related to habits that patients have. Perhaps we can educate them on the risks and really work with them to see what we can do to help them with that. And for our oral pharyngeal cancers, HPV vaccination will help protect against the HPV virus types associated with that malignancy. And finally, again, as I mentioned, the mouth is not disconnected from the body. So patients with medical conditions in the oral cavity sometimes fall through the cracks. This could be through whether they have a malignancy or some other kind of systemic condition that presents in the mouth. So these patients really need these bridges for us to be able to catch them and help them. Advanced stage oral cancer has significant morbidity and mortality. So the sooner we catch it, the better. A lot of the therapies that they're undergoing, whether it's for oral cavity cancer or another malignancy, have a lot of oral manifestations associated with it. Really, the classic one is mucositis related to chemotherapy. And then finally, we can see malignancies outside of the oral cavity that can metastasize or migrate or move to the oral cavity, and that accounts for about 1% of all malignancies in the oral cavity. And that leads me into my last research project, again, one that's in progress as we speak. And I've partnered with multiple institutions to review our metastatic malignancies to the oral cavity. It's rare, but it does happen, and we're trying to further characterize those. This is an example of a metastatic mesothelioma to the oral cavity. So that is the end of my presentation. Thank you for letting me speak with you, and I will turn it over to the next speaker.
Thank you very much, Dr. Glass. And Dr. Williams, while I pull up your presentation, do you have any comments or remarks that you would like to offer before we begin?
Oh, sure. So it was very interesting when I was invited to participate. I was like, oh, this is not my area of expertise. And then as I started developing the presentation, I realized, oh, I actually do a lot with oral cancer. So we'll see in this presentation.
Very good.
Good evening. I'm Michelle Williams. I'm an associate professor in the Department of Global and Community Health at George Mason University. This evening, I'm going to be talking with you about strategies for reducing oral cancer disparities. Just a brief overview about what I'll be sharing with you all tonight. First, I'm going to discuss oral cancer disparities. Then I'm going to talk about some general strategies that can be used for reducing disparities. And I'm going to end by discussing the See, Test, and Treat program in Mississippi as an example of a community outreach strategy that's currently being used to address disparities in oral cancer. Let's start by talking about oral cancer disparities. When we look at the data for oral cancer, we see that overall, white males tend to have the highest incidence rates compared to people of other races and ethnicities and genders. But when we look at the mortality data, what we see is that although Black males and American Indian and Alaska Native males have lower incidence rates, they have the highest mortality rates. So that's a significant disparity. What we know is that oral cancer screening, especially among high-risk individuals, and high risk can include those who smoke or those who drink alcohol regularly. And what we know is that one of the key factors that's driving disparities in mortality is that certain groups tend to be diagnosed with later stage oral cancers, which are much more difficult to treat. When we look at oral cancer research, what we see is that there are certain groups that have significantly lower intraoral or extraoral cancer screenings on a regular basis. One study found that minoritized racial and ethnic groups, people who live in rural communities, and those who are less educated, uninsured, or Medicaid insured tend to have significantly lower rates of cancer screening. We may wonder, well, what is driving these factors to have lower cancer screening rates among these groups? I looked at another study that specifically asked this question. These researchers conducted focus groups with African American adults and with dentists, and their goal was to identify factors that are acting as barriers to oral cancer screening among both groups. What they found was that overall, African Americans had lower levels of awareness about oral cancer screening, but also they found that dentists rarely engage in information exchange about oral cancer with their patients. I want to share a few quotes from this article because I'm a qualitative researcher, so I have a deep appreciation for qualitative data because it helps you to understand things from the participant's perspective. So these are some quotes from the article, and these are examples of patients' experiences with oral cancer exams. One participant said, "I'm just finding out that I've been having an oral cancer exam every 3 months, but I didn't know it was an oral cancer exam." So this quote speaks to the fact that oftentimes dentists may be providing or conducting oral cancer exams, but they're not necessarily communicating that with their patients. The participant also said, "I didn't know what he was checking. I thought he was checking for swelling, ears, nose, and throat." So therefore, this is evidence that providers can do a better job of providing information during exams to educate people about oral cancer and the importance of oral cancer exams. These are some quotes from the same study, and these are quotes from dentists, and these are quotes representing barriers that dentists experience to performing exams and communicating with their patients. And the theme for these quotes is that the dentist believes that patients have low receptivity, and they also have financial concerns about performing oral cancer exams. So for example, one dentist said you could volunteer to do the exam for free and they still wouldn't come, suggesting that even if people didn't have to pay for oral cancer exams, they wouldn't come and get them. Another quote from this study said, some of them don't want to do it if they think you're going to charge them for it. But if you say it's part of it, then they don't care. So again, placing the emphasis on the participants' expectations based on their perceived ability to pay for the screening. So these are some barriers that dentists experience in regards to performing exams and talking with their patients about oral cancer. Therefore, this information shows that there is education needed for dentists to help them become more confident in talking with their patients about oral cancer screening. That leads me into the next suggestion, which are some simple strategies for reducing oral cancer disparities. The first one is community outreach and free screenings. Now, as you saw on the quote from the previous slide, a dentist said that even if the screenings are free, participants wouldn't come and get them. Well, I have evidence that I'm going to share in a second that actually says otherwise. Another strategy is improved access to care, meaning making sure that people who are uninsured, underinsured, or Medicaid insured have access to regular oral cancer screenings. And the third strategy, my favorite, because my area is cancer education, is personalized patient education. And this is very important, especially among individuals who may have higher risk because of behavioral lifestyle factors like smoking or drinking alcohol. Now, I want to share with you information from the C-Test and Treat program that's been conducted in Mississippi for several years. As a matter of fact, last weekend, April 5th, I was in Jackson, Mississippi, because we were conducting another C-Test and Treat at the UNC Cancer Institute. And the fascinating part about this most recent event is that for the first time ever, we actually included men. So that was wonderful. But I wanted to share information from the C-Test and Treat because it's a program where we actually provide oral cancer screenings. So I'm going to share some data from 2024 since I haven't had a chance to analyze the data that we collected last weekend. So as you can see here, for 2024, the mean age of our patients was about 49.6, and the age range was 31 to 64. Well, let me tell you, the overall goal for C-Test and Treat prior to 2025 has been to offer Pap test, mammograms, and oral cancer screenings to women who are uninsured or underinsured in Mississippi. When we look at our participants by race, we can see that the majority were Black and African American, but we did have about a third of the participants who were white, 2% who were Hispanic, 2% who were Asian, and 4% who identified as other race or ethnicity. The great thing about this is that just about all of the patients that came that day had an oral cancer screening. So as you can see, this chart shows you the breakdown of the screenings that were had by participants. So some participants were eligible to get all 3 screenings. Again, eligibility was based on age. So for example, if a woman was not 40 years old, then she would not be eligible for a mammogram unless she was at higher risk. So, but as you can see, when we look at the breakdown of the screenings, the majority of the participants had an oral cancer screening in addition to another type of screening, but by far oral cancer screening was the most commonly had screening among the participants. I'd like to share this question because for our evaluation, we want to know why people are coming to our event. And as you can see here, the most common reason for coming to the event was getting the free cancer screenings. So I find it so interesting because I think back to the quote that I just shared with you from the dentist in that study who said that even if the screening was free, people would not get it. But as you can see here, the majority of the participants came because they wanted and needed a free cancer screening. Now, I have data about the impact of the program on knowledge and perceptions about all types of cancer, but because of course we're focusing on oral cancer, I'm just going to focus on the results related to oral cancer. So this question is about whether or not the program had an impact on the participants' understanding about the importance of having oral cancer screening. And as you can see, 96% of the patients said that the program helped them to understand why having oral cancer screening is important. So again, educating patients is important because during the event, they're not only screened, but they're also educated. Our providers intentionally educate them about the screenings when they're delivering the results of the screenings. This slide is just showing the results of a question that asks about the perceived impact of the program on the patient's knowledge and perceptions about the different types of screening. And as you can see, 93.2% of the patients said that the program increased their overall understanding of oral cancer. This slide I know is very busy, but just focus on the line that's highlighted in the red box. And so this question is asking about the behavior change they're going to make as a result of participating in our program. And as you can see, 41 out of 44 participants said that because of attending the program, they're going to get oral exams regularly. One of my favorite parts of doing the evaluation of our C-Test and Treat program is that I get to talk to participants and I get to get qualitative data. So the highlighted red box is again what I wanted to highlight because it so contradicts what the dentist in the previous study said. So this participant said the information and overall screening itself was the most enjoyed part of the program. The free screenings are helpful because I can't afford it otherwise. So again, more data that's showing that free screenings are quite impactful. Now, out of all the years that we've been doing C-Test and Treat, in 2024, we did have an incident with a patient and a provider, and it just so happened to be during an oral cancer exam. And I wanted to share this with you all because I think it highlights the importance that providers need to understand that patients are humans and that we have to treat everyone with a high level of respect. So to make the long story short, what happened is that this patient had an issue with the person who was doing the oral cancer exam for her. They didn't close the door when she walked into the room. In addition, the person did not have a pin light to do the exam. Rather, he used the light on his cell phone. And he wasn't adequately sanitizing his hands from touching the phone to touching the patient's mouth. And again, this is said during an interview that I did with her in a private room. And I could feel how impacted she was by that. And I just wanted to highlight that because providers need to understand that patients can have this type of experience and have such a negative impact on their future behaviors regarding seeking preventative care. So it's important that we all consider the patients when they're doing any type of exams. In 2021, we published a paper. I believe this was after the second or third C-Test and Treat that we had done. And this was highlighting our program and the findings that we've had. And this was actually findings from the very first year that we did oral cancer exams. So you can see in this figure the different types of exams that we did and the outcomes of the exam. In our very first year of doing oral cancer exams, we actually detected a stage 4 oral cancer. And so that is just so impactful to show that a free community screening event could lead to the detection of a stage 4 oral cancer. This person had no idea that they had oral cancer, none whatsoever. So imagine how finding out impacted their overall survival. They were able to get into treatment because our program ensures that if you have an abnormality, we're going to be able to link you to treatment. We're not going to just put you out there on your own. Even if you have to come back for a mammography with an abnormality, we make sure that you're connected to treatment and we see you all the way through the process. So our very first year, we found a stage 4 oral cancer. So I just want to go back to this slide, right? When I first showed these 3 things, it seemed so simple, and it is simple. Providing community outreach with free screenings works. Improving access to care for individuals who are underserved, uninsured, or Medicaid insured works. Providing personalized patient education works. So just keep these 3 things in mind in regards to strategies for reducing oral cancer disparities. Thank you so very much for taking time to listen to this presentation, and I'm happy to take any questions. Thanks.
Thank you so very much, Dr. Williams. I truly appreciate all of the work and the information and insight that was rendered in that. Very informative. And last but not least, we will also turn to Ida Kondori.
All right, hey everyone. Thank you, Dr. Glass and Dr. Williams. I do have questions for you guys at the end too. So, so over the years, I've worn many hats: clinician, instructor, and operations, and most recently, someone working to bridge medical and dental care to improve the outcomes. I'm particularly passionate about eliminating preventable inefficiencies while enhancing patient outcomes, because I've seen firsthand what happens when warning signs are missed or when patients fall through the cracks. So that's what brings me here today, because oral cancer isn't just a specialty topic, as Dr. Glass and Dr. Williams have also highlighted. It's a critical public health issue that affects families, clinicians, and entire communities. And I believe we all have a role in recognizing the signs, raising awareness, and bridging the gap between what we know and what we actually do in practice. So whether you're a student here at Mason, or a professor, or a frontline provider, or even an advocate, your impact surely matters. And next slide. So here's a quick look at what I'm going to cover. I'll begin with understanding who oral cancer affects, then touch on some prevention strategies, community efforts, and some exciting innovations in early detection. And then we'll close with some practical resources that you guys can either take a screenshot or, since it's being recorded, I guess just reference later. So this slide, it's a powerful reminder that oral cancer doesn't discriminate. If it can happen to Batman or Iceman, depending on your movie preference, it can happen to anyone. And Val Kilmer's battle with throat cancer, including the profound impact on his voice and identity, brought this disease into the spotlight. But for every well-known story, there are thousands more unheard. And as providers and educators and community members, we all have a role to play in prevention and early detection. So oral cancers, you hear that term, it's part of a group of cancers commonly referred to as head and neck cancers. And of all the head and neck cancers, they comprise about 85% of that category. Brain cancer, ocular, thyroid, these are cancer categories of their own, so they're not included in the head and neck cancer group as identified by the National Cancer Institute. And as Dr. Glass showed you with the images, it can develop in the mouth, throat, lips, tongue, gums, and tonsils. And historically, the death rate associated with this cancer is particularly high, not because it's necessarily hard to discover or diagnose, but due to the cancer being routinely discovered late in its development, specifically according to Oral Cancer Foundation. And these charts here from the American Cancer Society. So overall lifetime risk of developing oral cavity or oropharyngeal cancer, it's about 1 in 59 for men and 1 in 139 for women. And the image on the right was a projection in 2023. But as Dr. Glass highlighted, in 2024, we had over 59,000 new cases in the US alone. Average age of diagnosis is around 64 years old, but over 20% of cases occur in people under 55. And men, often due to higher risk behaviors related to lifestyle factors and habits, are nearly twice as likely to develop this cancer as women. So, which is why we still have to be vigilant and proactive no matter who the patient is. So let's talk about what we can do, because awareness is only meaningful if it leads to action. So on the left column, we see key prevention strategies that can truly save lives, including routine oral cancer screenings, where dentists are often the first to detect subtle signs like a persistent sore, ulcer, or white patch if it hasn't healed in 2 to 3 weeks. If I see something like that, I refer for a biopsy right away. And in fact, about 60% of oral cancers are caught during these kinds of routine dental exams. And we've also you've heard tonight about lifestyle changes, avoiding tobacco, limiting alcohol, using sun protection is important, and eating a nutrient-rich diet, staying up to date with HPV vaccination, especially for younger populations. These are all protective measures that can significantly lower oral cancer risk. But of course, we have to go beyond prevention, and we need to understand how coexisting medical conditions, or they call it comorbidities, can complicate treatment. And why? Because more than half of oral cancer patients live with at least one other condition like diabetes, cardiovascular disease, respiratory issues. And for example, I've worked with patients experiencing dry mouth from radiation or struggling with infections made worse by poor glycemic control from diabetes. And these challenges don't just affect the comfort, they impact healing and treatment planning and long-term outcomes. So, we have things that we can recommend, saliva substitutes. Xylitol, for example, it's effective in preventing cavities because it inhibits this bacteria responsible for tooth decay. And also stimulates saliva production. And kind of speaking about xylitol, you may have read or heard of the Cleveland Clinic study last year that highlighted some concerns about xylitol increasing the risk of a heart attack and stroke because it elevates the platelet responsiveness. So that just leads supposedly to a higher blood clotting potential. But it's important to note that the risks that were associated in that study with high doses of xylitol were in processed foods. So in comparison, like a piece of, pure gum, the PUR gum, it contains about 1 gram of xylitol per piece. So obviously when consumed in moderation, as with most things, xylitol in gum is safe and effective for stimulating saliva and managing dry mouth without the risks that were highlighted in that study. Another study I'd like to highlight, it's a 2021 study that was published in Acta Oncologica. It's a peer-reviewed journal in Sweden. And they found that patients with oral squamous cell carcinoma face a significantly higher burden of comorbidities than the general population, even 5 years post-diagnosis. So basically, whether they're pre-existing or developed comorbidities, it can definitely worsen the prognosis and reduce the survival rates. Next bullet here, just pretty much saying it's not just systemic diseases. We have oral bacteria that can contribute to cancer risk. There was a 2019 study published in Scientific Reports that found that this bacterium called Fusobacterium is associated with periodontal disease. It can promote tumor development by creating this pro-inflammatory microenvironment. So basically, it's just underscoring the importance of periodontal screenings as part of cancer prevention, because there's specific types of bacteria that have been linked to cancers beyond the mouth. And one type of Fusobacterium is called Fusobacterium nucleatum. It's been found or linked to colon cancer. So because the oral cavity can serve as a reservoir for these bacteria, It's important, for better prevention and treatment strategies for both oral and systemic health. And I'll later talk about some salivary DNA testing and personalized medicine that can help for high risk or immunocompromised patients. So again, oral signs of systemic disease can indicate broader cancer risks. Petechiae, for example, they're like small red or purple spots, and those can appear on the lips, on the buccal mucosa, on the soft palate. And if you have, any kind of patient who has or is undergoing chemotherapy, it suppresses the immune system, but it also weakens the oral tissues, and that creates conditions where secondary cancers like squamous cell carcinoma can develop. But of course, these symptoms can overlap with early oral cancer signs, so it makes differential diagnosis sometimes critical. So what does this mean for all of us? We're not just providers, we're advocates, early detectors, and our role is to look beyond the mouth, connect the dots, and especially coordinate care across disciplines to support the whole patient. So if we work together, the goal is to catch cancer early when it's most treatable and the outcomes are most favorable. And next slide. So luckily, we're not alone in this fight. I just wanted to bring attention to national and state dental associations that have made significant strides. April, as we now know, is officially Oral Cancer Awareness Month. The American Dental Association and Virginia Dental Association provide vital resources for screenings. And then you have local organizations, of which I'm a member of, like the Northern Virginia Dental Society, that are equipping the next generation of dental professionals right here in our community. So these partnerships, they help us reach more patients and connect them to care early, especially those who might not otherwise have access. And just to kind of highlight a little bit about what each organization does. The ADA, they set the national standard for dentistry, promoting oral health education and awareness, including oral cancer. They've developed clinical practice guidelines for evaluating potentially malignant disorders in the oral cavity. They've convened summits to foster collaboration between dentists and physicians and combating oral cancer. They developed the Give Kids a Smile program, which includes oral cancer education for children and families. And actually, the Northern Virginia Dental Society also hosts a Give Kids a Smile event every year, where dental volunteers provide full examinations, radiographs, and treatment. So if you want to, learn more about the resources or oral cancer screening and prevention techniques, that's on the ada.org website. And the Virginia Dental Association, we're very fortunate to have such an active organization. They are an ADA affiliate. They advocate for better dental care, access, and education across Virginia, including oral cancer awareness. They promote HPV vaccination as a preventive measure, and they organize free oral cancer screenings in community centers and local events to increase accessibility. A really great win. It was super important that this went through. They successfully lobbied for Medicaid expansion in 2019. In Virginia, adding a comprehensive adult dental benefit finally went through in 2021, which included oral cancer screenings for low-income adults. And these are made possible by, it's called Dental Days at the Capitol. Happens every year, where we have volunteer dental professionals that advocate for policies to improve oral health, access, and various initiatives. And there's also a new, if you like podcasts, they have a Fulcrum podcast. That's the name of it. It's an engaging and informative listen. It features episodes that explore various topics relevant to the dental community, healthcare access, workforce challenges, legislative matters, and things like that. And they are recorded. So that's right off the VDA website. And then the Northern Virginia Dental Society, it's the largest VDA component, serves over 1,400 dentists in Northern Virginia. They promote oral health education and community engagement. They also helped establish the dental hygiene program at the Northern Virginia Community College, which currently trains future dental hygienists and dental assistants. And there are 2 local free clinics that provide comprehensive treatment to underserved populations. And those clinics are located in Fairfax and Sterling. And this link at the bottom is, there's just some free publications on cancer, oral cancer. So it's a lot of great information and material there. So as you probably heard, and I've just kind of gone over the topic so many times, but awareness is powerful, but empowerment is what truly changes outcomes. And there's a February 2025 Cancer Research Institute blog that put it simply, early detection saves lives, but empowered patients drive early detection along with their providers. So this chart highlights the difference between early and late signs of oral cancer. Early signs are often subtle, persistent red or white patches that don't go away after 3 weeks, unusual bleeding, unexplained tooth mobility, and they can be easy to overlook or dismiss as something minor, but for us providers, they're red flags worth investigating. And then naturally, the late signs are much more serious. You have the hardening of the tissue, tingling or numbness in the lips, chronic ear aches that can signal a deeper, more advanced involvement. Airway obstruction, it might present as difficulty breathing or swallowing, especially if the tumor invades deeper issues. And then you have trismus or a limited jaw opening and enlarged lymph nodes. As Dr. Glass also mentioned, in the neck are also signs that the disease has progressed. And the conditions like diabetes and cardiovascular disease can definitely complicate treatment and recovery, which is why a multidisciplinary whole patient approach is essential, not just to treat the cancer, but to support every aspect of the patient's health. And on the next slide, there's a flyer from the Mouth Cancer Foundation. There's others, if you look online, similar to this, similar graphics, but this one was labeled as a 2-minute exam that could save your life, and it really could, because a quick screening during a dental or medical exam can catch early warning signs long before symptoms progress. But I like this image because it's simple, it's non-invasive, it's something we should all feel confident in performing or especially requesting. So this was a nice resource because sometimes we're always looking inside our mouths and looking at our faces sometimes, but we may not know exactly where and how to, what we should be looking for. So this is nice, 2 minutes. So we're entering an exciting era of oral care. As I was mentioning earlier, we have things like salivary diagnostics, like liquid biopsies that can now detect cancer before a patient feels anything wrong. We have AI that helps us interpret imaging a little bit more accurately as a resource. And for patients in rural or underserved areas, we have teledentistry that makes follow-up care more accessible. So they're not just tools, but I think they're game changers in terms of survival rates and patient experience. So to get a little bit more, liquid biopsy, it's a non-invasive way to check for disease like cancer. It analyzes fluids from the body, blood, saliva, urine, even cerebrospinal fluid. But unlike traditional biopsies, which include removing tissue, and a question for Dr. Glass, because I'm still sure that it's the preferred method for most dentists, but salivary biomarkers, they're a specific subset of these liquid biopsies that it's easy to collect, contains biomarkers from oral tissues like tumor-derived DNA or even HPV-related markers. So they're less invasive and another way to detect systemic cancers. A few notable companies that use this, Viome, Quest, and Oral DNA Labs offer these type of tests to detect for certain strains, especially HPV strains linked to oral cancer. Second, we also have companies like Overjet, which are primarily known for detecting caries, bone loss, and other dental conditions using an AI algorithm with their X-ray technology. It can support oral cancer care indirectly. Their FDA-cleared platform enhances X-ray clarity, and it highlights pathologies. But for oral cancer, this just means better visualization of abnormalities like radiolucencies or irregular bone patterns that might suggest malignancy, which is something that providers can further investigate. And then, of course, we have teledentistry. It facilitates remote oral cancer screenings and follow-ups, like MouthWatch, that enables remote consultations for initial assessments, allowing specialists to review images for oral cancer signs. And then the last point here involves genetic profiling to customize oral cancer treatment or prevention. And I really don't believe many patients don't think it's necessary to share symptoms or a family history unless asked. And sometimes they don't realize it's relevant. But that one conversation could really lead to life-saving discoveries. And today we have these genetic tools like Myriad Genetics and Oral DNA Labs that can help us create a more complete clinical picture. So I'll just give a little bit of information about each of these. Physicians, they can order myriad genetic tests like MyRisk. It assesses cancer risks, not just oral cancer. So it's like a broad lot of different types of cancer. It's open to any doctor, not just specialists, but oral DNA labs focuses more on salivary tests like OraRisk HPV. So dentists are the main users of that one, but really any licensed provider, physicians, even nurse practitioners can order them too if they're registered. You don't need a specialist title, just a clinical reason. So ask your doctor about these tests to explore these tools, especially Myriad. Okay, and then the last slide here, we'll talk about is that prevention doesn't end at diagnosis. Survivors need ongoing long-term oral health support, and patients at risk need clear, actionable steps to take control of their health. And as you see in this slide, we have key areas of focus, including managing dry mouth, checking for recurrence, addressing emotional well-being, all of which highlight the critical role dental care plays, especially with patients that are undergoing cancer treatment. And this concept ties into what Dr. Williams has shared with you about breaking down barriers and improving screen rates for cancer, especially among underserved and uninsured populations. Research shows that the number of individuals who receive cancer screenings, especially those who are at high risk, it's still kind of alarmingly low, which is why programs that integrate dental care during cancer treatment are so crucial. We see the importance of post-treatment oral health care, because as we see, survivors of oral cancer as well often face long-term oral complications like dry mouth, tooth decay, and difficulty swallowing. So starting with dry mouth or xerostomia, we have a few recommended actions. There's MI-Paste, which is a topical cream that you can apply to your teeth, comes from a milk protein. It's like fluoride with a couple other minerals. Xylitol, lozenges, and even humidifiers at night can help restore moisture. Hydration is another key area. So sipping water throughout the day, using alcohol-free mouth rinses, which I think is a great choice anytime. And trying pH-balanced options like alkaline water can help maintain oral moisture, soothe tissues, and balance bacteria levels. So you say alkaline, what makes water alkaline? It may contain minerals like calcium, potassium, magnesium that increase its alkalinity. Basically, some are naturally alkaline, meaning they're from mineral springs, and other waters may be artificially altered by adding minerals like the Smart Water brand. Research has shown that alkaline ionized water can help reduce oral bacteria, which improves overall hygiene. And a 2024 study that was published in PubMed found that alkaline water did significantly reduce bacterial colonies in the mouth. A common concern we hear from patients is loss of taste. Zinc supplements may be helpful in some cases, but these should be discussed with the provider. Manuka honey is another option that's both antimicrobial and soothing for mucosal tissues. Nutrition also plays a significant role. A diet rich in antioxidants like berries, spinach, and whole grains. It supports immune function and tissue repair. Essentially, avoiding excessive sugar and processed foods helps reduce inflammation and protect your mouth and overall health. So you might see a lot of books out there, talking about the keto diet, and a lot of patients use that or try to, undergo the keto diet for this reason. Of course, seeing your dentist or physician every 6 months even can be life-saving, or more frequently, depending on your needs. Ask specifically about oral cancer screenings if you don't know or if they aren't being done, especially if you or a loved one is at higher risk. Early detection is one of the most powerful tools we have because, as we've shown you tonight, it can improve treatment success and survival rates. So definitely talk about that family history. No detail is unimportant. For those undergoing treatment, skin and lip protection is essential, especially if radiation is involved. Products like Aquaphor and SPF lip balms can protect against dryness, cracking, and sun sensitivity. And then we have which becomes even more important during tri-fast, helps strengthen enamel and lower the risk of cavities, especially if a dry mouth is a concern. That's kind of like an off use for that. So to conclude, small daily actions can lead to major improvements in both prevention and comfort. And here on the right, I've listed or included a list of advocacy groups that offer education, emotional support, practical help, because no one should feel alone in this. And just the last slide, I want to thank you all for your time and commitment to making a difference. Whether you're a student, a provider, or a patient, you have the power to raise awareness, to ask questions, and help detect oral cancer early. And if you wanted to connect more after this talk, this is my QR code for LinkedIn. So thank you.
Thank you very, very much, Ida. And I also want to say thank you to all of our panelists here this evening. It's been an absolute pleasure to have you on to share your expertise. And I thank you for all the dedication and work that you put into coming into this conversation with these varied topics. But now I would like to open the floor to a little bit more of Q&A to dive further into this topic for those that are curious. So at this time, if you have any questions, you can drop them into the chat and we will respond in time.
I think I'm looking at the first question here about, is there a significant difference in survival rates between people who have routine dental care and those who don't? Maybe not compared to routine dental care, but I think we definitely brought up some statistics that obviously having that routine dental care and catching it early improves survival rates, because with oral cancer, timing is everything. Has there been any studies determine different patient education success rates between male and female dentists? In my personal experience, I've had much greater education success when I deal with a female medical provider versus a male provider. That's a great question. Is similar to the question I had for Dr. Williams, because I was curious, the interviews that you did, especially of the providers, were they all in Mississippi?
Yes, they were. Yeah.
Okay.
Well, and just
Yeah.
so the quotes that I shared, so that's not something that I did myself. That was an article that I
collected.
Yeah.
Gotcha. There was something kind of leading with this. So you say, I know every provider is different, but, and I think you mentioned this to me once. So when you have these screenings and the patients, they get the results same day. And then you mentioned that follow-up appointments are made for them. That kind of helps with the adherence. So what goes in, I guess, the process of who, I guess, are they following up with? Is it just in that institution or in the hospital, or I guess, do you need volunteers, or how does that work?
Yeah. So with that particular case, they were able to stay within the UMC medical system because we do have a dental school. So that particular patient was able to get their treatment within the UMC Medical Center.
Oh, okay. Okay, that helps. So they can just go within there. Okay. So yeah, I don't know if that answers your question, Mark. Now, when you say, female medical, so you're specifically referring to physicians or maybe specific specialty groups? I don't know. Maybe that would be a research for Dr. Glass to undergo.
And I will just add, when it comes to screenings, so all oral healthcare providers are required to do head and neck examinations as part of their comprehensive exam and their periodic exam. If you're billing those codes, you have to do it or it's fraud. So oral healthcare providers should be doing it at those appointments. But when it comes to the physician side, most physicians look at the U.S. Preventative Task Force to determine what screenings they need to do. And surprisingly, for oral cavity cancer screenings, it says that there's insufficient evidence to recommend routine oral cancer screenings in an asymptomatic population. So that means our oral healthcare providers are doing it, but our medical providers are not doing it for every patient. And then also our medical providers do not have the same background knowledge that our oral healthcare providers do. So I actually partnered with the Virginia Department of Health, and we went to free clinics to teach medical providers how to do head and neck exams. And there was a steep learning curve for some of our physicians in learning how to do the exams and what they're looking for. So I think that there's an area of education broadly when it comes to oral cancer screenings.
That's a very good point. Thanks for sharing that. I also had another question. I'm just, I'm always like looking at the research that gets published. So this is a question for you, Dr. Glass. What are your thoughts on vaping and oral cancer? I know that, I don't know how many, I'm sure you get thousands of biopsies that are sent to you, to the VCU from across the US. are you seeing any? I know you get background information from patients, but obviously, yes, smoking, we know all this, cons, not the pros about it. But every time I see research, they say, oh, it's not necessarily leading to this. So I don't know if it's just still early, but I wanted to know what you thought about, implications.
So I think there's no safe form of tobacco products, and everything carries a risk. And unfortunately, time will tell. So if those using those products now end up developing malignancies later on, we're going to see that. So right now, I have not seen a strong association. Most of what I'm seeing in our literature are unique burn patterns from some of these products. And then we've all probably have heard about some of our younger populations developing weird fibrosis of the lungs, requiring transplants at the age of 17. So we're seeing the acute side effects of vaping, and time will tell for those later on.
Yeah, that's a good point. And what the preferred? I mean, I know if I ask a general dentist versus maybe an oral surgeon, periodontist, I might get different answers. But between salivary testing and then obviously the traditional surgical or excisional or incisional biopsy, what is really, I guess, the preferred standard?
The gold standard is a tissue biopsy. A treatment center will not perform treatment without a tissue confirmed biopsy. There's lots of other kinds of adjuncts and screening tools on the market. None of them right now are necessarily better than a visual and tactile examination, but with all of these new things that are being studied, perhaps there are ways that we can improve our detection, but there's no perfect algorithm yet for some of these tools to screen. And that's what I hope to see in the future, is a better algorithm for the screening tools. But right now, doing that exam is key. And then a gold standard diagnosis is through a tissue biopsy, because you also have to realize if a patient's going to go under, if they're going to have a large resection where they're going to remove their mandible, like they need to make sure through a tissue biopsy that they have confirmed the diagnosis. And even after I sign out a case at the biopsy service, whatever institution the patient goes to for treatment, their pathologist also requests the slide and looks at it. So there are at least 3 eyes looking at this tissue slide to make sure that that diagnosis is concrete and clear prior to treatment.
Okay. Yeah, that's kind of how it seems. With the salivary testing, you can do it, but you're ultimately going to end up needing to do a traditional biopsy, which is kind of similar to, I don't know if everyone here, not really oral cancer, but you've heard of like Cologuard versus getting a colonoscopy. Yeah, it's better than nothing, but still, the gold standard, as you put it, is actually colonoscopy. So, okay, thank you. Any other questions? And frankly, I know this is going to be recorded. It'll just be posted on the College of Science alumni page, the recording of today's webinar.
That's correct.
I actually have a question, if you don't mind, for Dr. Williams. In your research, have you seen an intersection between what you're looking at and maybe environmental concerns or attributes? My background is in environmental science, and I work with communities that are at risk for climate change. And I just wanted to see if there, in literature, I had not even thought about oral health in my work. Thank you.
Oh, that's a good question. Unfortunately and unfortunately, so the work that I do with the C-Test and Treat in Mississippi, we don't consider that to be research. So we collect a limited amount of data. However, I do collect their zip code, so that is something I could actually look into to see like where they live and whether or not like they have any environmental risk in their communities. Environmental health was like my first passion in public health, so that is a very interesting question, and I actually would probably even just go ahead and say yes, because a lot of these people are living in very rural communities in Mississippi. So yeah, that's something I can definitely look into. That's a good question.
Thank you. Thank you. Very, very curious about that. Yeah.
Actually, Michelle, there is something I read, and I'd have to find it, but I can always send it to you later. But I remember reading something. It was published, I think, by NIH, but it was on PubMed, that was talking about the association between exposure to pollution and then increased oral health risks. So there may be something there. I don't know about studies in specific areas and cities, but I think, just pollution in general might, I think I did read about an association with, it was with caries and oral diseases and oral facial clefts. So I think that research is still new, but I think I saw something similar.
We'll hold the floor for just a couple more minutes here, but in the meantime, if you have additional questions that crop up after this webinar is concluded, by all means, please reach out to us via email, and I can collect questions and disseminate them to our panelists accordingly. And otherwise, keep your eyes peeled for the recording to be uploaded online. And oh, here, very good. Let's see what we have here. Oh, I appreciate it, Mark. Thank you very much. And on that note, I just want to say again here, thank you to everyone for the work and dedication they put into this, not just in the course of this evening's webinar, but the amount of work that goes into becoming the professionals that you are in this field. And I thank you for all of the dedication that you're rendering to those around you as we further our research, understanding, awareness, or screenings. And thank you for doing your part to bring awareness to the dangers and the outcomes of oral cancer.
Thank you so much.
I'd like to say, thank you very much to Ida Kondori, our board member, who pulled this together and did all the logistics. Thank you, Ida, for really educating all of us here on this important topic that we need to spend some time with, and especially during this month of April. So thank you to you.
Appreciate it. No, thank you. And thank you to Dr. Williams and Dr. Glass. It was good. We all spoke about something different. There wasn't really too much overlap. So I learned some new things this evening as well. So.
Yes, and thank you again for the invitation. I really appreciate it.
Anytime. Thank you so much. Okay, well, I guess no more questions. Okay, I guess Franklin will conclude the presentation here. Well, have a lovely evening, everybody.
Thank you. Have a great evening, and we'll see everybody later.
Thank you. Bye.